Okay, so welcome everybody. Thank you for joining this session that I am so excited I get to moderate. Our session today is being presented by two advocates, one a nurse and one a patient and advocate. And I will introduce both of them now. And I'm sorry to remind you all, I'm Karen Fleming. I'm the education coordinator for SCAGO, and I'm also a registered nurse who's been passionate about sickle cell for a while. And it makes me extremely happy to see some of my colleagues in the audience. I won't shout you all out because I don't want to miss somebody, but thank you guys for making that commitment and joining today. So Nia Navarro is an emergency nurse out of Toronto General Hospital and a founding member of the UHN Emergency Department Sickle Cell Working Group. She holds a Bachelor of Science in Nursing from Ryerson University and has been a guest lecturer at the Kronstadt School of Nursing in Port of Spain, Trinidad. Over the last decade, she's worked in a range of emergency settings, managing the nurse activities with MSF on the Rohingya crisis in Bangladesh, medically transferring patients around the world as a flight nurse, and working in the Cleveland Clinic's emergency department in Abu Dhabi. Nia is currently working in remote First Nations communities in Northern Canada. She believes in the profound healing that could come from a decolonization of the structure of healthcare, whose workers are in service and partnership with communities, building autonomous, self-determined agendas for their health and healing. And then I just want to introduce Serena now so that they can just flow through their presentations and we don't have to stop for this. So then the second presentation will be done by Serena Thompson. She lives with sickle cell disease, and after experiencing years of humiliation, misunderstanding, and isolation in schools, hospitals, and her places of employment, she became engaged in the sickle cell community as an advocate by joining committees, championing for patient-centered care. She recently served as the interim president of the Sickle Cell Association of Ontario and a member of the Minister's Patient and Family Advisory Council. Excuse me. What has happened is my 9-year-old's downstairs and I told him to be quiet and he's doing a bunch of stuff and I'm being distracted by it, so I'm sorry about that. And a member of the Minister's Patient and Family Advisory Council, Healthy Debate, Medical Doctors Admissions at U of T, Patient Alliance for Patient Safety, Patient Caregiver Advisory Group, and Patient Partner Advisory Group. What she doesn't have on there is that there it is, Ontario Health Standards, I was going to say. So Serena is now serving on the Healthcare Excellence Canada, UHN's Emergency Department Sickle Cell Disease Working Group, and is one of the co-chairs of Ontario Health's quality standards that we just heard about earlier today. So thank you. So welcome to both of you. We'll let Nia get started and then Serena will go and we'll have time for questions at the end. Thank you.
Hi, good morning, everyone. Thank you for that introduction, Karen. So my name is Nia Navarro and I'm presenting on behalf of the UHN Emergency Department Sickle Cell Working Group. I don't have any financial relationships or sponsors to disclose. Okay, so the UHN Emergency Department Sickle Cell Disease Working Group is made up of patient partners, community organizers, patient advocates, nurses, and physicians. Together we founded this working group in 2020.
Nia, I'm sorry to interrupt you. I just want to make sure the interpreter has said that she can't hear you well. And I agree. I think maybe just sit a little closer, maybe to the mic. Yeah, just to help out. That would be perfect. You're going to pop in your earbuds. Thank you. We just want to make sure everyone hears what you say.
Can you hear me okay?
That is awesome.
Okay, great. So in identifying an issue with how patient care is managed for those with sickle cell, encountering our emergency departments, we formed this working group. The vision statement to guide our group is to advocate for excellence in the care of patients living with sickle cell. We wanted patients with sickle cell to expect that their symptoms and concerns would be taken seriously. We also recognize that stigma and anti-Black racism have been and continue to be barriers to care for patients with and families living with sickle cell. So we committed to supporting initiatives designed to interpret the interpersonal, organizational, and systemic racism faced by the patients that we serve. So through cooperation with patients living with sickle cell, community advocacy groups, and healthcare practitioners within the emergency departments and across UHN, we are committed to making our emergency departments a place of support and safety for those with sickle cell disease. We also wanted to clearly identify patient-centered markers of impact of our work, which we will report at least annually to the broader emergency department team and to our community partners. This vision led to our quality improvement strategy. I wanted to start with a hypothetical patient case study. Travis. Travis is a 20-year-old man of Afro-Caribbean heritage. He presents to the emergency department with a 2-day history of worsening chest pain. Travis has a history of sickle cell disease, and his last vaso-occlusive crisis was in March. He's called into the triage office. The nurse checks his vital signs and asks for a pain score. The nurse sends him back to the waiting room with a CTAS-4. As he walks out of the office, he hears the nurses speaking to each other. He was on his phone the whole time. How can he be a 9 out of 10 pain? These sicklers are drug seeking. Barriers to care. Many of us have heard about known factors leading to sickle cell crisis, like cold weather, dehydration, and illness, but stress and trauma and anxiety are also triggers for crisis. The stress from racist perceptions and stigma literally keep our patients sick. Sickle cell patients who are seeking care have the added layer of stress, having to think about how they will be perceived by the healthcare workers receiving them. Many feel burdened by respectability politics and will dress up nicely as a strategy to avoid judgment or to be seen as worthy of care. Fears around the opioid crisis are valid, but opioid use disorder is not driven by patients with sickle cell. Inadequate and undertreated pain causes repeat visits and complications for those in vaso-occlusive crisis. In the same way, we don't say addicts. Sickler is an offensive pejorative, dehumanizing the patient by minimizing them to their disease. In a 2013 study, healthcare workers identifying their patients with this term resulted in negative attitudes towards them and a lower quality of care for patients in crisis. According to our patient partners, many patients with sickle cell delay their care due to the stress of having to tolerate racial stigma, therefore increasing poor outcomes and complications. Coping with pain. Sickle cell disease patients' pain is often dismissed if they're not performing pain in a way that's deemed appropriate. Pain presentation is subjective. There are many behaviors and coping strategies used by chronic pain patients as distraction techniques. Chronic pain is often invisible, but needs the same level of urgency and importance as those experiencing acute pain. Patients with sickle cell are experts at managing their pain. So if a patient in a pain crisis is asking for food or is talking on their phone, is pacing or requesting a warm blanket, these may be signs that these may not be signs that they're feeling better. In many cases, these are ways that they're trying to manage their pain and could actually be signs that they're feeling much worse.
Okay, back to Travis. Travis waits in the emergency waiting room for 1 hour and is sent to the ambulatory part of the department. He sits in a chair for another 45 minutes until he's called to be assessed by the nurse. They take a brief history and recheck his vital signs. Travis's vital signs have worsened. His heart rate and respiratory rate have increased. He now has a low-grade fever and lower oxygen saturation. His pain is now 10 out of 10, and he has crackles in his left lower lung. The nurse remembers there is an order set for sickle cell pain crisis and approaches the doctor to initiate treatment. Standardizing care. Referencing the provincial 2017 clinical handbook for sickle cell disease and vaso-occlusive crisis, the target time for analgesia is from ED triage is 30 minutes. Our working group wanted to focus on measuring the time to pain medications from triage registration to analgesia administration, which was an objective measurement that we could track over time. An order set is a comprehensive set of medical directives and orders based on different conditions or common presentations. So they have treatment steps that are used by providers to guide care. The sickle cell order set was initially developed by the University Health Network Emergency Department and the Red Blood Cell Disorders Clinic, with many coinciding with the Sick Kids order set. This became a primary focus of our working group, as well as increasing its timely use. Because an order set can only be helpful if us as healthcare providers use it. What our working group found in our comparative study with renal colic patients was that 90% of sickle cell encounters had used the order set in comparison to renal colic, which was less than 20%. Sickle cell encounters using order sets received their first opioid analgesia 66 minutes sooner than those without order set use. And the difference was not seen amongst the opioids administered in renal colic encounters. Advocating for our patients. To advocate for our patients, we must acknowledge that there is an implicit bias that exists in healthcare. We can also advocate by implementing educational opportunities and implementing order sets as a standard of care to override the inequitable treatment of patients with sickle cell disease and their experience in vaso-occlusive crisis. Patient and family education is important, and by connecting patients with advocacy groups and interdisciplinary resources goes a long way in making sure that our patients are supported, as well as continually monitoring for avoidable complications. This goes beyond administering analgesia. Okay, Travis. So once the order set was initiated, Travis was treated for his vaso-occlusive crisis with the appropriate medications that have brought his pain level down to 4 out of 10. Although due to the delay in care, he now needs to be admitted to hospital for acute chest syndrome. Travis feels like he hasn't received compassionate, adequate care during his experience in the emergency department. He feels an overall apprehension towards the inconsistencies in his care and the attitudes of the healthcare providers that he encountered. Therapeutic relationships and trust. Failing to acknowledge that patients' reports of pain contributes to historic mistrust and hesitancy within this patient demographic. Overall, it causes longer suffering and affects the therapeutic relationship. It's important to address the wholeness of the patient by looking at their social determinants of health and making the appropriate referrals. Back to Travis. Travis is admitted to the general medicine floor for 3 days. After x-rays, CT scans, antibiotics, oxygen, blood transfusions, pain medications, and IV fluids, he is feeling better. He's missed work, and his immediate supervisor is threatening probation if he's sick one more day. He's not sure how to make ends meet if he loses his job. What could we have done to better ensure that Travis's experience was more successful? Acute chest syndrome for Travis and others with sickle cell is very dangerous in a vaso-occlusive crisis. Early treatment leads to a lower mortality and shorter lengths of hospital stays and a less chance of reoccurrence. After this experience, Travis could have a reluctance to return to the emergency department when he needs it. We know that delayed care leads to worse outcomes, and there are discrepancies with funding and research in Canada for those with sickle cell, which eliminates a lot of support for patients of this demographic. Hospital admissions affect patients and their families holistically. So treating a vaso-occlusive crisis appropriately from initial triage could have a greater effect than we think. It's so important for us to discharge safely, to advocate for our patients if they don't feel ready for discharge, to make sure that the patient is tolerating fluids by mouth, to make sure that the pain is manageable on oral anesthesia, and any unaddressed acute medical issues are met. It's important for us to ensure that a follow-up plan is documented within their chart and that hematology or the red blood cells disorder clinic have been notified of the patient's discharge, and that social work or any other necessary interdisciplinary groups have been consulted. Also to make sure that prescriptions are provided if necessary. What can we do as healthcare providers? We can remember that pain is subjective. Patients living with chronic pain can be invisible. So understanding this, that we should treat this pain with the same urgency. We can standardize care and ensure shared treatment planning. Also, we can support coping strategies like meditation, listening to music, eating, praying, walking. And we can teach our peers and our coworkers who may lack the knowledge and advocate for those who cannot. Thank you very much for your time.
Awesome. Thank you, Nia. My timer was just about to go off, so that was perfect. Yay. Okay, now, Serena, thank you. We'll go ahead and you can share your slides.
Okay, can everybody see my screen?
Yep, it's perfect.
Wonderful. Thank you very much. Thanks, Nia. Thank you, Karen. I'm here to present about unconscious bias, the challenges of behavior and emotions. What is bias? The definition of bias that we can find so far, it says, as a noun, it's prejudice in favor of or against one thing person, or group compared with another, usually in a way considered to be unfair. It's also a verb, cause to feel or show inclination or prejudice for or against someone or something. So I talk about anchoring bias. So anchoring or focalism is a cognitive bias where an individual depends too heavily on an initial piece of information offered when making decisions. So ultimately, anchoring bias can lead to incorrect diagnosis or a delay in arriving at the correct diagnosis. So here's a checklist. Know what proactive steps and practices to take to minimize unconscious bias in decision-making. What conscious bias might look like in an emergency room. Notice how unconscious bias can impede the effectiveness of delivery of care, and recognize and understand the impact of unconscious bias in everyday interactions. Also, understand and address the consequences of unconscious bias on your performance, impact of conscious bias on patients' diagnosis and recovery, and strategies and practices to overcome and avoid unconscious bias as a patient and a healthcare provider. So how can we recognize and understand the impact of unconscious bias in patients and everyday interactions? Don't be apprehensive in getting to know your patient, even though it's in sometimes it will be in the ER, sometimes it will be in clinic, sometimes it will be during admission. Get to know the patient instead of just knowing them. Get to know them as a person instead of a patient, basically. Ask questions to learn more about your patient's situation. You never know, something could have happened that day where it triggered a crisis and they had to come in for treatment. You could learn about their situation. Maybe, recommend on how to prevent that from happening the next time. Try not to assume anything about them and their situation without asking questions first. Notice how unconscious bias can impede the effectiveness of delivery to a patient about their diagnosis and treatment. So with sickle cell, double check your diagnosis. Did you skip a step thinking you've seen the case before? Is your treatment of the patient based on their status? That's a very important one. Is your diagnosis based on what you think it is because it is typical amongst people like them? And we want to stay away from saying phrases like that because everybody is different when they come into the ER. Are you not connecting with the case because you feel there are other important ones to tend to? So what unconscious bias might look like in an emergency room. So unconscious bias drives unconscious behavior. Imagine a patient with sickle cell disease walks into the emergency department with a calm face, dressed in sweats or pajamas, and no one is with them. What are your first thoughts when the patient expresses their pain is 10 out of 10. The patient has visited the ED several times in the past couple of months. How serious do you take the patient's claim? So here is, once again, just mentioning, the unconscious bias drives conscious behavior. The patient comes in a crisis. showing no pain on their face because it is something that they're used to. Maybe they might be grimacing, but it is pain, 10 out of 10 pain. Most of the time we're very used to hiding it in our facial expression. And then we're dressed in, we're dressed down. That's what we would call it. Dressed down, which is, not dressed up in, our everyday work clothes and so forth. We could be in sweats or PJs because of the time, because of the time of the crisis. Know what proactive steps to take to minimize unconscious bias in decision making. So listen to your patient, listen to exactly what it is they're trying to tell you, where the pain is at, what is going on at that moment in time, and hear them. Believe your patient, understand that, as we said, pain is subjective. Understand that that patient is seriously having a pain crisis and it is an emergency. Ask pertinent questions related to the current situation, as I mentioned before. Understand your patient and assure them that you're going to treat them as best as possible. That alone would just reduce the anxiety and the doubt that we as patients have every day when we step into the ER. Know what proactive practices to take as well, which is continuous self-evaluation and education. Provide education to staff to reduce stigma. Staff education through webinars and lunch and learns, and be accountable and transparent. So recognize the bias and try to minimize it as much as possible through these steps. And strategies and practices to overcome and avoid unconscious bias as a healthcare provider. So to reduce your own biases, when you're signing out on a patient, ask for the facts of their current medical complaint. Discourage disparaging terms such as frequent flyer, which we've always heard, or hospital hopping, malingerer, crazy, or drug seeking. So non-compliant and so forth, and do not use them personally. Frequently reassess your patients when the clinical exam does not correlate with the laboratory data. So I've always heard stories where patients will go in for crisis, and then after that, once their labs come in, they're told that they're not in a crisis when actually they are. So forcing yourself to think of alternative diagnosis and new information you gathered. Most importantly, treat the acute pain adequately, regardless of past history. So we're just saying, treat the pain once we're there and we present with a crisis. Take home points. Anchoring could be reduced if clinicians consider previous similar visits, if any. Actively seek information that could disprove the current assessment. Frame their diagnostic thinking to avoid premature labeling and share uncertainty with colleagues and patients. And this is where we've always said, if it is possible, if it is not possible, or you do not feel 100% in the treatment of your patient, it's always good to reach out to colleagues or the patient's hematologist or their doctor, and use system-based interventions, including structured diagnostic assessments, diagnostic decision support, or computerized expert diagnostic systems. And take action. Beware of bias. Is it enough to eliminate it? Research suggests that while there is no way to eliminate bias, it is possible to develop strategies to reduce its likelihood of occurring. So these include limiting words that might introduce bias, reporting only factual, not assumed, so never assumed, and information, and being careful to separate personal decisions from personal feelings, and developing cognitive walkthrough strategies for scenarios in which bias is more likely to present. So we're just saying, you know, just be aware of the bias. It does exist. We all have it. We're just saying, just recognize it and realize, okay, we're a human being first, and we're here in pain, and we're seeking help. Here's my references. And I wanted to say thank you so much for listening.
Awesome. Thank you, Serena. And Nia, you can pop your camera back on. And if you stop sharing slides, Serena, that would be great. Guys, thank you very much for just putting it out there. And from both perspectives, it was interesting that you're both actually presenting from opposite lenses, but that they're the same perspective, right? It's the same message that you're sharing around the experience. So thank you. It was nice to hear the alignment and the joint moments, such as language. Language was something I heard clearly. It's about a little bit about the language we use and the impact that language, the words we choose, how that can have an impact. And the other thing I really pulled from both of you is that individualized, personal, like we really need to look at each patient individually, which we've always kind of been told. So it's interesting that we really need to reinforce that. So I would like to open up the floor for questions. We've got a good 7 minutes at least. And so you guys can, if you need to unmute yourself, I think if you raise your hand, then I can unmute you. So if you would like to unmute yourself, just raise your hand and then I can let you do that. Or please use the chat or the Q&A if you do have a question for Nia or Serena. A message in the chat from Annette. Serena, just so you know, thank you, Serena, for sharing your message. Extremely powerful. And it's really true. Hearing it directly from those that experience it, it really sticks. Like we can talk about what we believe patients experience, but it's very validating for me to know that, the things I'm like, no, we cannot do this. This is not right. To hear that from you, to hear your voice, it's very helpful. Just helps to reinforce it and continues to burn the fire, because it's unfortunate that this is the way things are. So if nobody else has questions, I definitely do. So one of the things I heard Serena say was around this idea of having to hide the pain you're having. So, you hide 10 out of 10 pain on your face, like you've kind of trained yourself how to do that.
Yes.
Can you tell me a bit more, like why if healthcare providers, and I didn't mean to, I just want to give you a full sum and then you can definitely go ahead. If healthcare providers need to be able to allow you to self-report, and part of that self-report and part of our assessment is visual in nature. And what I'm curious about is if you hide the pain on your face, does it make it even harder for a healthcare provider to kind of align with what you're telling them? That's where I'm kind of going.
And I do see that happening because I understand they would have to maybe see the pain to maybe judge how bad it is, kind of thing. But most of the time, I think it's because it's almost embarrassing. It's almost embarrassing at how bad the pain feels, because all you do is just want to cry. And then you're in a strange place, and then you don't know the people. You don't know if they're going to have sympathy or empathy at all. And so you just keep it to yourself. When I think about it now, I think it's more of an embarrassment. It really is. And because it's excruciating pain. So then we're just able to just keep our face straight. And because Well, we're used to the
Mhm.
situation, not used to the pain.
Mhm.
Yeah.
Mhm. Yeah, the external factors, right? Like the environment in which you go to, the treatments that you've experienced, you're used to, unfortunately. And I'll say that word probably a lot throughout these 2 days, is what is there, right? Is that trigger? It's what you envision. And so that's certainly, try to make myself look better. Is it try to make myself look like more accepting? I don't know. I know it's something, I feel like it's something along those lines, but hearing you say the words,
It's
embarrassing. Mm.
yeah.
Mm.
So it's a little bit embarrassing, and because you just want to just cry, you just want to let it out, the intensity. But then what does that look like in an emergency room, when, especially if we've been told by our own doctor, do not make a scene, do not come in there and raise your voice, do not if you're crying in there, it's not going to make things go faster. So when we hear stuff like that from someone who's supposed to be taking care of us, then that's what's making us stay quiet.
That's really interesting. I'm coming to you, Annette, for sure. Because I've heard even the opposite. So I've heard that some providers have told their patients to kick up a stink. And so I generally chime in there to say, well, I don't think that messaging is good either. Either messaging to me doesn't really work. It just perpetuates stereotypes either way.
Right.
And so for you, the provider, it's that implicit bias. They're telling you that message through an implicit bias lens. You really, you don't want to replicate that mad Black woman, you don't want to, like that whole thing, right? And without knowing it or knowing it, that's how that comes through. Even them saying that to you, like,
and when it was said to me, I didn't understand that it's, bias at that time. I understood it was more I can't even, but it was more like, okay, well, you don't know me, one, you don't know the type of person I am, you don't know how I am during a crisis, you don't know what happens when I come into an ER, but you're assuming. So I had to make a conscious decision at that time to switch my doctor, just because of that comment.
Wow.
Yeah.
Okay, let's invite Annette in. She's been patiently waiting. So Annette, if you have a question, right, sorry, let me come here and allow you to talk. Okay, you should be good now.
Thank you. Can you hear me okay?
Yes, we can. Thank you.
Thanks. Not necessarily a question, Karen, so sorry about that. I have more of a observation and a reflection. Serena, again, thank you so much to you and Nia for sharing. Annette, I'm the Director of Practice for Oncology and the Blood Disorder Program at UHN, and an oncology nurse by background. I think what was extremely meaningful, just as I was listening to you, and almost like aha moment on a personal level, is when you talked about the need our patients feel to dress up to go to the emerge in the middle of a health crisis, in an acute pain crisis. And it's an aha moment for me personally, because as a child of an immigrant, and also doing that same thing when I go or when I take my family, but without actually realizing the rationale for why I do what I do. But I think what you shared really brought to the forefront, certainly for us as healthcare workers, to really be reflective of that immediate judgment that we place based on individuals when they come to our care, whether it's a clinic or an emerge, environment. And so I just wanted to share that reflection. That was a personal aha moment and a professional aha moment. But truly, what a terrible, terrible place do people have to be, that in the midst of a medical emergency, in a sense, they actually have to be mindful of how their hair is, how their skin is, how they're dressed, in order to ensure that they're respected and seen. And I think that's an important message that I'm taking away for sure. So thank you for that.
Thank you.
Yeah, I think, thank you so much for making that comment. I was just typing feverishly to look for a video, but I can tell people a video you certainly can watch that. Every time I watch it, I get teared up for sure. It's called Crisis, CRISES. It's on YouTube, and that video, probably about 7 minutes or so. It's all about the experiences of various individuals with sickle cell, and exactly what Serena was saying, having to get dressed up, like in the middle of things, thinking about putting on, like, like actually thinking about that is insane. I agree with Annette's thought there. It just seems this is not the time. Like, just get in the emerge. I just want to get the care I deserve. And so having to just really stop, and you yourself have to think about the healthcare providers' assumptions that they may lay. So therefore I want to reduce those assumptions, and I have to go through this whole, what do I do to help reduce those assumptions, is highly, highly unfortunate. And yeah, we're going to make change go.
I think,
Yeah.
Karen, when you were asking, what's like, what's that impact like? I have to say, like, also, not just only I used to think of dressing up and going into the ER, but I also thought about, should I walk in or go in a wheelchair? And I want to walk because of my pride. But then my colleagues will say, no, you need to go in a wheelchair. You can't walk. So it's so strange. Like, I'll dress up and then I want to walk in and be able to catch somebody's attention and worthy of being able to be looked at and be taken seriously. And then once I got older, I realized, no, I wheelchair. It's wheelchair. Stop being prideful. And I think that's another thing within the culture of the community. I think it's the pride as well. And that's why also we're not showing the emotion. We don't want people to see the vulnerability in us and so forth. So it's hard.
Thank you for sharing, Serena. Honestly, thanks for being here. Nia, did you have anything to add? Because I certainly, through your experiences, you've been in a number of different settings. So before we kind of sign off to go to our next session, I really want to open it up and give you an opportunity if you want to add anything.
No, I think it's so important for us to listen to our patients. So it's so great that Serena is sharing her experience, and just to, like, going forward, to just really focus on the patient and their experience, and like their holistic experience, not just, they're coming in crisis, but what does this mean for their life and their livelihood? So just to keep that in mind, that we're not treating a patient with their ailment, we're treating people and their experiences living with this illness.
Awesome. So guys, I see that I have a few questions. Okay, so I got 3 questions in the Q&A, and I see Annette pop something up in the chat as well. So let's start off in the Q&A. Thank you both for your unique perspectives. I'm wondering if there is a role for community and primary care nursing in managing VOCs outside of the ED. And then Serena, what has been the experience of patients in those settings? And I want to pause for a second. Because our session time technically is up, I want us to please answer that one question. And then directly to Marcia, I might just type back an answer that I think is correct, and I can confirm with Nia. And then for Annette, the orientation, Nia can answer that question right after Serena answers this. Or either of you guys, wondering if there's any role for community and primary care nursing in managing VOCs outside of the emerge. So whoever wants to take a stab at that.
Absolutely. I would think, management equals prevention. The vaso-occlusive crisis at the time, I think, would definitely have to be in a hospital setting. But, within the community and primary care nursing, like, I think if there was some way of managing, like, I would say, involving the patients in the management of their care, involving them in the management of the care. So not just telling them what to do. This is what you need to do, this, and this, but actually involve them in their care, because there's so many outside factors that can, bring somebody to crisis several times throughout the year. It could be, they're stressed about housing. They could be stressed about their financial situation, stressed about employment, their family, their kids, all these outside factors. If the community was able to provide, more resources to help with the families that are going through these difficult times. So I think that would help.
Thank you. And then Nia, can I direct your question to Annette's query? If the Emerge nursing orientation training, did the training include implicit bias, like those particular pieces beyond, I guess, just your traditional pain management?
In terms of orientation training, like, no. And also that was so many years ago for me, but we do have, within our working group, we worked really hard on education within both Toronto General Emergency Department and Toronto Western Emergency Department. So Serena and another nurse in our working group, Ruth Pia Boateng, they both worked really hard on these education sessions. So just, when we were changing our order sets and, just going over implicit bias and sharing information with the group, both Emerge doctors, nurses, everyone in between, of how we can better treat our patients in the emergency department. But within nursing orientation, there's so many other things that they focus on that there's not really much time to focus on specific, like vaso-occlusive crisis in the Emerge.
And I hear I totally hear what you're saying, Nia, but I also think our organizations completely pick what they want us to focus on. And they choose on how deep they get into the information. Whether it is that we get implicit bias training, period, like just talking about it and how does it impact us as providers. I would think it's coming more and more into organizations to do that. But I agree that there's not like this set sickle cell education period for nurses or doctors. But if it is included, it doesn't tend to lend to that implicit bias racism. Like, how do those actually impact the care provided and received by patients, provided to and received by patients? So thank you guys. Like, this is part of it. You want to have a session like for a whole hour, just like, let's just go, because there's always great questions. And I got more, but I'm looking at the time carefully. No one's tapping me on the shoulder yet, so I'm trying to avoid that. So guys, we're headed into the plenary session number 2. I first of all want to thank both of you. Thank you for getting us all started. Like, already I've got ideas jumping. So really great having you guys here. Please, I hope you stick around and join other sessions. And as of course, self-promotion, tomorrow I am presenting on a virtual simulation game I created for sickle cell. It does talk about implicit bias. It was one of the very objectives in there. And one of the patients from PAC and who's speaking is actually the patient in the virtual sim game. So we can continue this conversation tomorrow. So plenary session 2, human rights, equity for individuals with sickle cell disease, is happening. So please leave this webinar and head into that session. Thank you all.
Thank you.
Thank you. Thank you so
guys.
much.
Okay.
Bye.
Bye.